we know that we have a genetic evolution in CLL. We have particularly seen that after chemoimmunotherapy, that at relapse situation, the CLL clone coming up usually had some additional adverse genetic lesions. And so the question is now, with the targeted treatments, do we see a similar picture? For a time-limited treatment with venetoclax plus obinutuzumab, there are some first data from the CL14 study in elderly patients, where we see at the relapse that there are no BCL2 or MCL1 mutations, for example, well-known resistance mechanisms to venetoclax. However, the numbers of patients with relapse are so far scarce, so we have to definitely need a longer follow-up. So with the BTK inhibitors, we know that BTK mutations, for example, are one of the major resistance mechanisms. There are probably also others in BTK inhibitors. However, it's not yet the time point where we should test these resistance mechanisms in clinical routine. We definitely have to do that in clinical studies. With respect to the established prognostic factors as TP53 mutation, this should be retested at relapse. At least I would strongly recommend that in all patients who are either young and fit enough to undergo an allogeneic stem cell transplantation, because we know these patients still have a poor prognosis if they develop TP53 mutation, or if in the center there's a clinical trial evaluating, for example, other cellular therapies as CAR T cells or bispecific antibodies, possible treatment options, which we hope particularly work in these high-risk CLL patients. The IGVH status, also discussed frequently, does not have to be retested, because it's when for the developing CLL, it will always remain the same, therefore it does not have to be retested.